everyone. This is Chadi Alraies from SCAI-TV in Atlanta. I'm really privileged today to be with Dr. Morton Kern. He is a professor of medicine at UC Irvine, and he is also chief of cardiology at the VA Long Beach. Dr. Kern, always nice to see you.
Thank you, Chadi. Pleasure to be here.
You did today a phenomenal session about IFR and physiology and highlighting how low we are implementing physiology and imaging in our lab nationally, which is a big thing, and there's a big push from you and other governing body to use it more. Let's start with this topic first and how we can implement more, and then we'll move to the next question.
Okay, so implementing the imaging and physiology into our daily practice, it should be incorporated because we're looking for best outcomes. And actually a complete interventionalist should be able to use these tools. And the goal is to reduce, believe it or not, in-stent restenosis. 10% of cases have in-stent restenosis across the nation. The cost of in-stent restenosis is huge. The mortality of in-stent restenosis is actually huge at 5 years. There's almost a 50% mortality. Nobody appreciates this very much. And if we do a good job in the lab using both physiology and imaging, you reduce in-stent restenosis, better outcomes, better patient care. It offsets the cost of using the devices in the lab because you don't have that guy coming back to the hospital system with in-stent restenosis. Very expensive. Bypass surgery, multiple readmissions, multiple problems. It's expensive. So physiology and imaging will help reduce that ultimate problem, make you a better operator, make your patient's results better.
And the panel touched on the reason of not acquiring this technology in the lab. So what are the barriers? Why we cannot make intervention?
Well, I mean, there really are no barriers except for the budgetary constraints. And some hospitals are not ready to pay the money. Some hospitals are not driven by physician perception of need, and reimbursement is missing. And so the Society of Angiography, our society, is working to get those things done. And I think that's one of the benefits of being in the SCAI.
Absolutely. Moving from implementation to one specific question,
Yes.
which is keep coming back. IFR or FFR of a donor vessel to a CTO territory.
Okay.
How to interpret this, and when to intervene on the donor vessel and when to intervene on the CTO vessel?
Oh, so good question. So let's just set the stage. So you have an LAD with a 70% lesion. It supplies an inferior collateral to a right coronary artery system that is occluded. You measure the FFR. I'll stay with FFR for the moment. FFR in the LAD, and it's 0.79 or it's 0.81 or right around the border zone. Now, it supplies all the flow to the interwall and the inferior wall, and if you open up the right, theoretically, you'll decrease the need of blood to go to that bed because it comes in an antegrade fashion, and the FFR in the LAD would go up. So it would go from 0.79 or 0.82 up 2 or 3 units. So you go from a borderline positive to a negative. Okay, right. So if you can open up the CTO, then perhaps you should. Now, alternatively, you could say, well, if I have a borderline FFR in the LAD and I treat it, then I'm going to give better flow to both beds. So that's an acceptable approach as well. But if it's negative, if it's 0.84, 85, 86, you don't need to open it. It's getting enough blow, even though it's supplying a bigger bed. And, if you make it a smaller bed, it'll go up even higher.
So the argument is you can go either way. Again, giving the fact that if you want to intervene on CTO, you want to make sure this myocardium is viable, and before you proceed with that.
Well, theoretically, yes. The indication to open a CTO should be that, yeah. But if you can do it and get rid of the collateral bed, the FFR should be remeasured in the LAD and determine whether you need to do it. Now, remember, I think a third of the time when that is done, you open the bed, a third of the time no change, a third of the time it goes up, and a third of the time it goes down a little bit.
One nice comment you made at the session is about the LIMA pullback.
Yes.
And to rule out diffuse disease instead of focal
Yes.
tandem lesions.
Yes.
Can you please comment on that?
Yes. So the case we saw today was an LAD LIMA anastomosis, and what looked to be kind of diffuse disease or maybe under pressurized vessel. So they selected an area where the IVUS and the FFR suggested there was a focal lesion. But a pullback wasn't done. So they treated the focal lesion well. The angiographic appearance looked good. The IVUS appearance looked good. But the vessel distal still had some question. and they concluded with what they had done, but they didn't give us the final FFR or the pullback. Remember, the pullback will talk about the recovery of pressure over a distance, and if it's gradual, that's diffuse disease. If it's focal with a step-up, then there's a lesion at that point of step-up. I think it does. Now remember, in the PCI, defined PCI data that Jeremias and colleagues put out, 20% of patients had a residual significant lesion. And of that 20%, 20% were diffuse. And so there's an 80% focal lesion to treat most of the time.
Okay. Now, when you are going from left radial, I'm a little bit pushing to that area,
Yes.
to do intervene on the LIMA, where do you normalize usually?
In the subclavian, yeah.
Having the fact that subclavian is free of disease.
It must be free of disease, because if you got a gradient between the aorta and the subclavian, then the LIMA flow is challenged. Yeah, you might have some reversal or steal.
Yeah.
So that's a good question. Nobody's ever asked me that. Where do you normalize it? But you normalize it in the artery, because that'll be your reference value against that. Now, left radial, left distal radial. So I use left distal radial. Yeah, because it's more comfortable for me and comfortable for the patient. But it
and in this guy, they presented the distal radial access trial, comparing to showing it's safe and the hand grip and function intact.
Right. So safe as radial, equal or better patency, and no loss of function. It's a wash. And the only thing is, it's harder to do. So you have to be a real pro.
We come to you for a class.
Yeah, real pro. Anyway, I think it's a great
Thank you.
technique. Yes, thank you.
Thank you, Dr. Kern, for your time. Really, I always appreciate the nuggets you give us during these meetings about physiology. Please watch these videos and others on SCAI-TV. This is Chadi Alraies from SCAI-22 in Atlanta. Thank you so much.
Thank you.